Okay, good afternoon, everyone. And I'd like to start by thanking SAGES for the opportunity to present today. My name is Savannah Renshaw, and I'm a public health researcher at Ohio State University. And today I'm going to talk about one of our recent projects looking at the role of insurance status in postoperative outcomes for patients undergoing ventral hernia repair. Let's see. And I have nothing to disclose. So health disparities represent a growing area of interest in health services research. And one of these reasons is because understanding who needs what is critical for allocating resources, but also designing the most effective interventions for the patients who specifically need it. In a variety of fields, low socioeconomic status has been linked to poor postoperative outcomes. And this ranges from complications, infections rates, even to mortality. And one of the ways that we look at low socioeconomic status is insurance type. In the absence of a better marker of the ability to understand an individual patient's financial situation, insurance becomes this surrogate marker that we can use to kind of get an understanding of where they're at financially. What we know from previous studies is that patients with public insurance types like Medicaid or uninsured patients have worse outcomes compared to our commercially insured patients. And this looks like increased complication rates, longer length of stays, and increased mortality, as I said. And the field of surgery is no exception. However, most studies in the surgical space looking at insurance type as a marker of financial stability look at things like complications and mortality, but do not necessarily account for other important metrics like healthcare utilization after surgery, specifically things like emergency department care. So for the purpose of this study, we sought to investigate differences in postoperative unplanned emergency visits for patients undergoing ventral hernia repair. To perform the study, we used a retrospective review of prospectively collected data in a national hernia registry. This is a quality improvement database. We included all patients aged 18 or older undergoing ventral hernia repair, and then we further stratified our study population by insurance type and created 3 distinct comparison groups. Private, commercially insured patients, public, Medicaid type patients, and then we also included a 3rd comparison group of self-pay or uninsured patients. The following covariates were included in the analysis. We used standard demographics, comorbidities of interest like hypertension, diabetes, and current smoking status, clinical characteristics such as ASA class and hernia size, and then our 30-day outcomes, which included complications, unplanned ED visit, readmission, and reoperation. So our study ended up containing just over 17,000 patients, of which the vast majority were privately insured, and then another 8% made up the public insurance group with 6% in the uninsured group. Our study was average age 50 years old and predominantly male and white. Our univariate analysis found that there were significant differences, even at this level, between each of our groups, which, as you can probably expect, rates of all of the comorbidities were almost significantly higher or significantly higher in our publicly and uninsured groups. This persisted at the hernia characteristic level, with our publicly insured and uninsured patients presenting significantly more frequently with non-elective repairs and recurrent hernias. They also had larger hernias and overall higher disease severity as indicated by that ASA class. Univariate analysis of these outcomes all demonstrated that they were significantly more common among our uninsured and publicly insured patients. So then, to assess for the independent association of insurance type on these outcomes, we built multivariable logistic regression models, controlling for demographics, clinical characteristics, and comorbidities. This adjusted analysis showed us that even after controlling for these differences in hernia presentation, demographics, and all of those factors, our publicly insured and uninsured patients still faced increased odds of experiencing each of the outcomes as compared to the privately insured reference group. So as you can see, complications were higher for public and uninsured, and in each of these outcomes, the uninsured group actually fared the worst. And it's notable to point out that those ED visits among uninsured patients, it was almost double the rate of our privately insured patients. So a couple of important conclusions to take away from this study. We found that complications were significantly more common among public and uninsured patients. We also found that public insured patients and uninsured patients returned to the ED much more frequently and exhibited that greater healthcare utilization after surgery. And implications and future directions here, it's important to note that vulnerable patients may require specialized pathways as we demonstrate these notable differences in the way that they heal in the 30 days after surgery and what types of healthcare they utilize in the form of emergency care. We may be able, as clinicians, to better address those psychosocial needs or other factors that are contributing to these differences. And overall, as a public health researcher, I think it's important to note that this is an opportunity to increase health equity and better care for our most vulnerable patients. So I would like to thank Ohio State for supporting our work and my colleagues here who helped make this possible. And with that, I will take any questions.